Welcome, everybody. We're so excited to have you here today uh, for this special presentation of Hope Zoom with our guest, Dr. Elizabeth Godfrey. So for those of you that don't know us or don't know me, my name's Adele Jason, and I'm the president of PMP Pals. And I've got a little slide that I would like to share for those of you that are not familiar with us. Okay, can everyone see my screen? Okay, so PMP Pals, we are the world's oldest global volunteer-run organization providing support to patients and caregivers affected by appendix cancer and PMP. We have a variety of programs that I have listed here. Our Hope Zoom meetings, which is what we have today, and today we have a presentation. And when we don't have a presentation, it's a twice weekly peer-to-peer support. Or you can connect with us in person at our annual meetup. We have physician presentations and resources from an educational perspective. We perform one-on-one mentoring. We have a variety of support programs, our card program, Bare Bottom Bears, and Barad's Blankets. We also have a special caregivers corner for those that are caregivers. Caregivers need support as well. And there's a QR code to our site. We've been supporting patients and caregivers since 1998. So I hope you will connect with us either through info@pmppals.net or through our Facebook page. So with that, it is my pleasure to turn it over to Dr. Elizabeth Godfrey. Many of you will remember we had her on one of our Hope Zoom calls when she was starting the Decisive survey, and many of us provided input into the survey. And so today she's here to give us the results of that survey.
Hello, everybody. It's exciting to be here today. Very humbling, also given how much you guys shared and how generous you were with your time. So I just want to thank you for that before we even get started. Um, so today I'm talking about experiences and decisional outcomes after cytoreductive surgery. This is an analysis of the survey that I did, and I'm also going to tell you a little bit about what comes next. I'm Dr. Godfrey, and Nicole Aguirre, or Nikki, is also on this call. She came from New York to join my residency program this past year and has kind of taken up the torch as I've gone back to clinical practice over the last year, and it's been really wonderful to have her helping drive this forward. So disclosures, there is a patient care clinical excellence center at University of Chicago called the Bucksbaum Institute, and they kindly supported this with a small grant. I am a surgery resident, which means I am still a physician in training. I'm not yet licensed to practice independently or provide, clinical advice.
Gonna bother you while I start this? Please just do the laundry. Turn off the.
And then just as a note, there will be a couple of artist renderings of anatomy and surgery in the presentation, but there's no photos and nothing, graphic. I want to acknowledge you guys first. Thank you, Adele. Thank you to the entire group. Also all of the other patient advocates and support groups who have spent time with me, spent time with this project, donated their time and their energy, and of course all of the faculty and the research team here at Yale and the clinical team who have really contributed not just to my training and to our patient care, but to this whole initiative. I'm going to go over a couple of slides that are just background for this project. I'll go over them quickly. I know all of this is old hat for you guys. You've been through this, so you don't really need explanations. But what prompted this project and what I talked to about sort of our institutional and grant supporters was the fact that patients like you guys and their caregivers, people facing peritoneal surface malignancy or PMP, just have really exceptionally, unique barriers to having good decision quality and outcomes. And what I mean by that is not necessarily that the clinical part, the the outcomes of surgery are difficult, although that's a different barrier, but that it's harder to make those decisions and to go through that process than it is for a lot of people dealing with cancer, because it's very high risk, high reward decision making. There's a lot of other treatment exhaustion. There's a lot of looking for doctors to take care of you, looking for the right cytoreductive surgery team, and there's just so many people who don't understand what you're going through and really can't support you in the way that people who are maybe able to support people with more common cancers. And in a lot of those common cancers, there's these tools called decision aids that are developed by educators, by clinical support teams that help people navigate the process, but that's not the sort of thing that has historically been available for people with PMP. So decision aids are sort of designed to address the problem of making a decision about a medical procedure or a surgery or a treatment when you're already facing symptoms that make it hard to think clearly, when you don't have adequate information, sometimes no support from people who know how to get you that information, and often people who aren't really asking, what is important to you, and they aren't always good at having that conversation. By they, I mean us on the clinical side. So decision aids are tools that make choices or the choice that you're facing explicit and clear and describe what that looks like. They share with you the data that has been shown to matter the most to people facing the decision. And then they show you how that choice relates to the values that either you elicit as part of the tool or that are known to be important to people making the decision. And they've been found to work really well. There's at least 100 of them out there that have been studied that show they increase knowledge. They decrease the sense at the end of treatment of feeling like you aren't satisfied with your decision. They also can help decrease the stress of the decision while you're going through it. So to address this, we did this survey called the DECISIVE Survey and invited patients and caregivers to characterize what their experiences in making decisions about CRS were like. The survey had 117 questions, and that is a very unusually long survey to ask people to take, so I'm extra grateful that people took the time to do it. Anybody who had PMP or PSM and their caregivers who had ever considered CRS were invited to participate. And folks like PMP Pals, ACPMP, and Town, kindly helped get this out there so that people could have their voices heard. And then once we got all this data, our team at Yale did kind of a two-pronged analysis. We had some questions that were multiple choice that we did a statistical analysis on, and then we had a lot of free responses that people sat down and really told us their stories and their experiences. And so we did what's called a qualitative analysis, where we did an inductive and a deductive analysis. We had a whole team reading through responses and associating phrases with certain concepts, and then synthesizing them together so that we could see what were common patterns and common experiences that people had. Over 140 people actually finished the whole survey, which, like I said, this was a very long survey, almost unheard of to get that kind of response. So thank you again. I just got a crash notification, so my Zoom may flicker out for a second, and I'll hop back on as soon as it's back.
Yeah, we can still hear you and we can still see the slide.
All right, I think I'm back. Sorry about that, guys.
Yes, we can hear you, but now we can't see the slides anymore.
Okay, I'm resharing.
Thank you.
All right, we got it?
Yes.
Okay, sometimes with the weather, my internet goes out. Okay, and we had 113 people who had cancer themselves respond, and 33 who were caregivers. Almost everybody who took the survey was somebody either responding on behalf of or who had undergone CRS, so we don't have as much information from people who chose not to have it, but that's still a great group of responses. The first thing that I wanted to establish with this survey, and Dr. Greenbaum has studied this too, and some of you may be familiar with her work. She's at University of New Mexico, and she's also really interested in how to help people make decisions better. For the folks who had cancer, who responded to the survey, about 14% had what the scales designate as moderate to severe regret. And that doesn't always mean thinking that it wasn't worth it to go through the process, but just meaning that there were parts of the decision process that really weighed on them. Only 11% of people who had cancer themselves said that the treatment they chose wasn't worth it. On the caregiver side, and I think this will ring true for some of you, there was a little higher rate of that. It was about 23% on one scale and actually 35% on the other scale. And I think some of that speaks to how much caregivers really need support and often don't get it for the the emotional and the physical and logistical, all the things that a caregiver really carries, trying to help out their loved ones. One of the things that I really wanted to figure out as well is when you have such a great group of people who are sharing their experiences, can you tease out what are the actual priorities that matter most to people? Because we as doctors and clinicians think we know what matters to people and aren't always good at making sure we really know. And what we found is that unsurprisingly, people said, prolonging life, stopping the progression of cancer, that's really important to them. And then kind of right after that, some people, it was more important, some people a little less, but focusing on quality of life and controlling symptoms. Logistical issues like, affordability and transportation and family support were very important to some people, less important to most. So that was important to know that we, what is important to account for when we're supporting people's decisions in clinic. We also wanted to know what are the barriers that people said made it hardest to make the decision. A lot of times we as doctors assume, the problem is that we're not giving you the right information and things like that. And that is a problem, but there's also a lot of challenges that come from a cancer diagnosis and the symptoms and the whole setup that is around coming in for the first time or second time or third time to talk to us that we also need to account for. And the number one thing that people said made it hard to make a good decision was just the emotional symptoms and the feelings surrounding a cancer diagnosis. And people also reported there's a lot of mental and physical health symptoms that are also barriers. And that's really important for us to be able to prove through doing work like this so that we can get better support from our hospital systems and our clinical partners and colleagues at all around the country so that we can say, hey, it's really important when you're helping people make a decision to make sure that you're addressing the symptoms they're having so that they can think clearly enough to be able to face these decision processes. But one thing I especially want to highlight is that a fair number of people said that not having good information about risks and benefits of treatment and what treatment was going to look like said that made the decision difficult. And there was also a lot of people who talked about experiencing confusion or poorly coordinated communication between members of their medical team or different medical teams they worked with. And both of these things, I think, speak to the limited information that's available out there that the public has access to. And that's something that a decision aid can specifically help with. Now, I apologize because these graphs have a lot of information in them, but I think it's the best way to see the comparison between folks who told us they didn't have enough information and folks who did, and that helps us point out where the challenges are for not having enough information about cytoreductive surgery. So the top three answers, blue is sort of good responses, red is negative responses. The bottom two, red is good and blue is negative. So the bottom groups in each pair are people who said they didn't have enough information. And more people said that they regretted the choice they made, or that they felt a lot of harm had resulted from the decision-making process when they felt they didn't have good information. And so then the next question is, what information are we around the country as clinicians and researchers not good at giving people? And the answer was typically around the risks and side effects area, which we already saw when we asked people what were your barriers that you faced. So about 1 in 4 people said they really just didn't get a good picture of risks and side effects from their clinical team. This is another of those same graphs that shows people who felt they had good information and people who felt they didn't, side by side. Again, that risks and side effects problem comes up every time. And then we also asked what specific topics in terms of information did people feel were lacking. And I would say overall, people reported the best information they got was about the preparation process for surgery, which still isn't always great. 26% of people said that they didn't get enough information in that domain either. But it was still the most favorable of the categories. And thinking about prognosis, what is life going to be like after surgery? What is even, really blunt questions like survival time, which I think a lot of doctors are afraid to talk about, but people want to know. And this illuminates, and when this is published, will hopefully help encourage doctors to be more clear and better at communicating that, because it's important to people making this decision. This is a graphical summary of the free response questions and all of the really detailed stories people told about their experiences. And it fell into 4 categories. People told me the key information sources that mattered to them. Support groups and talking to other sort of survivors or people going through the same process was the most important source of information for people. And that's, I'm sure, no surprise to all of you, because I know what kind of, work PMP Pals and other groups do. People also talked a lot about how they navigated the internet, how they used it to help support their journey. And said a lot about how they worried about the quality of the information out there. And then kind of the least important of the important information sources was actually the doctors and the clinical team. But people did share with us that if trust is established, if the team is good at communicating, then they become, very important. Another topic was the quality of getting to information, the quality of getting information delivered. And again, we had that concept of prognosis and disease information, and how it's really hard to get that information from anybody. The risks and benefits of treatment came up again here as a theme, that a lot of times the risks and the unexpected complications are not well communicated beforehand, and that makes it even worse when they happen, because you didn't have an opportunity to anticipate and prepare. And there also was a lot of really helpful comments on how we strike an emotional balance with how we talk to our patients, that we often way skew too positive and it's not helpful, or too grim, and that is completely unhelpful as well. People shared some nice, detailed, meaty, pointers on what kind of information and support they need. So disease and treatment specific evidence was requested a lot, but also just making sure that information is on demand, that it's something you can refer to, not just when you're in the clinic, not just, when you're having a conversation with somebody, but that you can refer to later, that you can look at, that you can think through. And of course, early referral to support groups and survivor networks came up over and over again. And the final point that I think relates maybe less to the specific topic of decision aids, but is something that is really important for clinical teams to know, in terms of how best to support people going through this process, are how much of the weight of your medical care you all carry alone. or just with your caregivers, and how much we're often not carrying our end of the burden. That people are getting delayed and incorrect diagnoses, that maybe the first doctor they meet is at a small hospital that doesn't have a lot of expertise, and we can do better as a medical profession at making sure that those people have the information they need to get you where you need to be. So I honestly, I think Nikki and I are going to write a whole separate paper about that. That's a call to action, because this is so pervasive across everybody that I talk to, that everybody's having to do this on their own. They're having to find their own doctors, and really feel responsible for their own survival. And, I'm so grateful third hand just reading through how much support groups and survivor networks help to get people where they need to go, because certainly a lot of medical professionals are not doing it for them. So once I had kind of gone through that thematic analysis with the team, we looked at, okay, now that we get the broad overarching ideas, what are the specific pieces of information that we need to put in any educational and decision aid tool? What are some specific numbers and pictures and explanations that we can put together that will be helpful? And the number one thing that came up that people mentioned that was sort of an I wish I would have known item was perioperative complications. I think there's such wide variety, and I can speak to this as a surgical trainee and how much we talk about these things preoperatively. But I think overwhelmingly we're not talking about them enough. And that doesn't mean that we should, scare people about them, but we should definitely be open and clear and talk about what that healing process might look like. Returning to normal life and recovery, and what is the new normal was also really important. Giving people an idea of how much time it takes, and what some steps are that we can take to help get people there, collectively. Specifically gastrointestinal changes and symptoms, what it's like to, maybe eat differently, have different bowel function was a really important topic as well. And then the survival and prognosis data came up several times. I think we as doctors have some ideas about, survival time, and we all are reluctant sometimes to say what that is, because the collective data that comes from the papers that are out there, it's really hard to know, does it affect the person in front of me? Will they be different? Which side of this, graph are they going to fall on? But we need to do better about conveying that information. And then finally, and this makes sense thinking back to the things that people said were their barriers to making decisions. Mental and emotional health symptoms that come from treatment and come from cancer came up a lot. And there are a lot of extra burdens to this kind of surgery because it's so huge, that I don't think we're communicating steps to manage and relieve those symptoms. And knowing that that's expected, but that we have things that we can do to make them better and alleviate them is really important. And so one thing that I think became clear that we need to address in a decision tool is what to expect from the mental and emotional health standpoint. So conclusions, most people said that they were glad for the treatment they had gotten. They felt they had made the right decision. And caregivers reported, like I said, a little bit more decisional burden. 64% of people who took this survey identified at least one need that they felt they had not gotten enough information about before they made the decision. And not having enough information makes people much more likely to have regret. So all in all, this is a way that the study allows me to communicate to the outside world how much we need interventions for this process. So moving on to just a little sneak peek at what we've been creating with a medical educator and illustrator. We are thinking through like ways to communicate information about cytoreduction and about the healing process and about the disease itself. So I just wanted to show you these illustrations that Lauren has put together for us, Lauren Halligan. And some of the realization of what was needed really came to me from presenting to you guys last year when I was starting this project and realizing how unhelpful some of the diagrams and public data and information are about this. So Lauren's put a lot of effort into providing some visual representations that are actually, I think useful and easier to understand. And also she's just very skilled. So we appreciate her contributions. So we're also working with her on figuring out how to represent some of those complications and outcomes that people said were really important to them. So just summing up and writing clear scripts and clear graphical representations of what some complications might look like, how common they are, what the process for treating and managing them looks like. So that's the process we're going through with Lauren right now. As we go through this, we have some patient advocates that are offering their feedback as we go. Many of you actually volunteered to offer your feedback as well. So the time will come when we'll have enough material that we'll reach out and talk to some of you about that. But once we have a tool that is in sort of a final form, it won't be the final form, but we're going to do what's called a pilot trial at Yale in our clinic, and hopefully this will start before the end of the year, where we give people in our clinic this tool, and then after their surgery, give them an additional survey and interview and figure out how much it helped, what wasn't helpful, what was more helpful, and then use that to refine our tool. And that sort of encompasses a couple of things. It encompasses how easy is this tool for people in the clinic, like our clinic nurses, our care managers, to help people access the tool, to help them go through the tool. How easy is it for people to get the information they need, and also how they perceive the tool to be. And then the final point is, what does this change the amount of regret that people have? Does it change how satisfied they are with the information they get? And all of that will help us then make a case for getting this bigger and more available to more people around the country. So the end game is we would love this to be publicly available to everyone, but we need to continue to get some financial support for development and maintenance, which means we have to have more centers test this, try this, offer their refinements to get there. So it's a process, but it's one that I'm really excited about so far. Okay.
Okay. Thank you, Dr. Godfrey. If there are any questions, if you could place them in the chat, and Dr. Godfrey would be happy to answer any questions. And I have to say thank you for making us feel heard. I think we probably all saw ourselves in the slides that you have there, and early conversations, early information is so important. And as you were going through your presentation, it really struck me how this survey and project that you're doing is one of the I think a response to the call to action that we had with the International Patient Manifesto.
Yes.
And so many of us contributed to that, and we've mentioned that in some of the information we've put out. Dr. Godfrey was also there when we were able to present it, but it really was a call to action from the patient community to the medical community on addressing some of these issues. So I think it's perfect timing and very responsive. Okay, there's a question in the chat. What grades of disease did this cover? I saw one of the first slides stated low grade, but did not see if it covered low, high, and or medium.
Yes, so we did have respondents from all grades. I did highlight for that demographic slide that about 44% of people who responded had low-grade disease. And the reason I mention that is just because when we think about how to, what information is needed, we have to think about, what percentage of the respondents belong to each group, so we can think about how the treatment, which differs slightly for each, might affect people's opinions and feelings about the decision. But yes, we had people from all grades.
On the slides that you had that were some of the responses, were they either moderately or severely regretted? Do you think there was a correlation between that situation and not having information, resources, support early on?
I think there is. I think let me check actually. I have a table that Nikki put together recently that talked about that looked at, how many miles did you have to get, how many doctors did you have to see.
Mhm.
Let me see if I can pull that up just so I can answer your question. Nikki, if you remember the association, feel free to jump in. Internet's taking forever. So I'm not going to make you all sit here while I look through all my emails because it isn't in the one I have in front of me. But I
Okay.
think people definitely mentioned that having a hard time getting information made it made the whole process, certainly more unpleasant. But I did also notice a pattern that I think speaks to the resilience of all of you guys, where people said, I really had all these barriers and I got no help, but I'm really happy that I got where I am because I did so well with getting that myself and with the support from support
Yeah.
groups. So I called that sort of the I don't have a good name for that. If you think of
Mhm.
one, let me know. But just the sort of um, success in spite of all of the barriers.
Yeah, I totally agree. And we talk about that a lot among ourselves as well, that sometimes our medical team underestimates the strength and resilience of our patient community.
Oh yeah.
Let's see, another question in the chat, and you can probably see it, is a barrier patients have is having appointments with doctors across state lines.
Yeah. Yeah, that's a huge challenge. I just spent my month on with Dr. Taraga. We kind of rotate around, so I just spent my this month on my home turf.
Mhm.
And that came up a lot because we take care of folks from all over the country, but we also take care of a lot of folks just from one state over. And there's a lot of issues with the US medical system and just making it really hard to deliver care across state lines. So I absolutely agree. And I think that's something that can go in that can really be highlighted when we cover that fourth category, the self-advocacy category of responses, that this is something that we could do better and it would make a huge difference to patient care.
Then the other question in the chat is asking, with recovery, have you had input from physical therapists?
Yeah, so we have some documents at Yale that our physical therapist team member Scott has put together, and we also have some older documents that are sort of shared among Dr. Taraga's colleagues around the country. And so I think a lot of that material, as much as we can turn into sort of a good online format, we're going to try to put in there.
Yeah, so the final tool will have input from nutritionists, physical therapists, at basically every team that would be involved in postoperative care and preoperative, preparation will be involved and have a script within the tool because all of their input is really important.
Yeah, I think that that tool is going to be critical, and hopefully when it's done, that's something, we can post as well, and just spread the word, because it's very, very overwhelming at all stages of the journey. Initial diagnosis, surgery, recovery, recurrence, the additional treatments, and so all of that is helpful. Let's see. Oh, we have somebody that won the iPad for participating.
Awesome. I think this is the first time I've come face to face with somebody who did after we finally got it to them. Man, that was the whole thing with our reimbursement department. But another team member, Jackie Moses, she did some really quality work squeezing those iPads out of the office.
Yeah, that's great. I'll let you read the other question that's in the chat and take that.
Yeah, I read it. So I think that this is part of what Dr. Godfrey was talking about. So the question is
Mhm.
primarily that the patient has had really good care in Cleveland, but that sometimes she feels she or they feel that they have to describe the procedure to their PCP, which is unfortunately a little bit reflective of the lack of knowledge of this disease in the medical community itself. And it's great that you're able to get a good surgeon in good care. And part of this is just us publishing more and getting the word out to the medical community. And as the disease becomes better known and better studied, it will become a larger and larger part of medical school curriculum. So younger doctors coming out will have more knowledge. But yeah, unfortunately, it is a knowledge issue. So part of this lies on us in publishing in journals and then the physicians in reading those.
Yeah. And even things that are, I think, increasingly, medicine is a really, and I'm using the word in the traditional sense, not the political sense. It's a very conservative field where we move really slowly with new information. And as many of you know, Paul Sugarbaker really started creating and popularizing this mode of therapy in the 80s and 90s. And it's crazy how long it takes us to adopt things in the medical profession. And I think that's even more so in cancer treatment than other areas because um, it can be hard to get um, sort of those outcomes data to prove that what we're doing works because when you have rare diseases, when you have things that are really hitting people hard, you want to move as fast as you can and give everybody the same opportunities, and that sometimes makes it hard to get the data because we're just doing what we can for everybody.
On the education again, so when our patients go to the specialist centers and then they come back home and they have a local medical oncologist and their local PCP, what sort of coordination should get done, between the surgical team and the teams they have back at home? How do we know we're getting the right surveillance?
Yeah. I think a lot of this comes back to some sort of side along work that Dr. Traga is really passionate about, which is how do you make a CRS HIPEC center that really does what it needs to do for patients going through this journey. And one of those things that he's been very passionate about, and he has a great team to promote, is making sure that you have the coordination, folks. It is I think from the purely, looking at a piece of paper aspect, you don't think how important it is to have somebody whose full-time job is to call all these PCPs and medical oncologists and say, this is what this person needs. We need you to help us with this. We will help you. And just that back and forth where somebody's job is to coordinate. Like, even in this world where everything's electronic, it's still so easy to lose information and recommendations. So I think and Adele, you met Dana and
Yes.
Evelyn, and they're amazing, and they're just so critical to how Yale functions as a high-tech center. But we need Danas and Evelyns all over the country. Like, they matter more, I think, in the long term to patients than people like me and Nikki. Like, having those people to carry the torch and train new people how to do it too.
And I think it's really complicated because we don't have a standardized way to set up a center like this. So Yale runs differently than the University of Washington out in Seattle, and how they coordinate. So some centers will have satellite centers throughout a state or something, and then you obtain your chemotherapy there, but your main care is centralized. So it's I think we're still in the process of studying, as all these different ways come out, what is the best way to make sure that we're providing the most up to date, appropriate care with the least amount of burden put on the patient. And it's hard, and we're starting to figure it out, I think. And it's getting studied, which is good.
Yeah.
Yeah. So, what can we do to continue to help? I know you said you have some participant volunteers, but what else can we do? The results of this and the tools, very, very important to our patient and caregiver community. And anything we can do to help, we love to do that.
Yeah, Nikki, do you have any thoughts?
I think after we go through the pilot trial, which shouldn't take very long because we don't need to do it on that many people. It's more of a feasibility study. Then we'll begin the process of kind of trying to go nationwide. And that's where association with groups to help us almost infiltrate other universities and other places, like someone who has a physician in Cleveland, and we can be like, oh, that's a great place, but we will discuss this with Cleveland, things like that. Because I think in order for this tool to be successful, it really needs to be nationwide. If it's successful here at Yale, we've helped our patients, and that's not enough. We want to help everybody.
Yeah. And I know this isn't like a now thing, but it is exciting, and it's a way that I think people like you guys will be very important in, the imminent future. Is right now we're kind of trying something where we're bringing on something called patient navigators from people who have gone through this process, who can sort of help walk patients through the experience and be available for questions. And I think when we show how important that is at a place like Yale, even though we already have all these resources, I think that'll really help us get more centers doing that, to sort of expand the impact. And so people like you guys will be the people who we call upon to be a part of that initiative.
Great. We had another question in the chat. What is the best way for patients to find clinical trials for their specific disease?
Yeah, I think there's the DIY way, and then there's the phone a friend way. And then if you're really lucky, then you're at a place like Yale where there's Dana's and Evelyn's and Boomies and Kwasis, and there's some of Dr. Traga's research fellows who are, spending all their time thinking about that. But um some people spend a lot of time on the National Clinical Trials website, and they actually go through what all of the criteria look like, and then they, reach out themselves or they share with others. I know that over at ACPMP, sometimes I get some emails, and I'm on some threads with Deborah Shelton, and she helps connect people sometimes, and that organization kind of looks at clinical trials. And I know you guys sometimes connect people when you know. Um, I have some I still don't know the right ways to use all these AI resources that are coming out, but I do know people have been asking some of these AI portals to help them find them. And that is potentially a really good resource because that AI portal can take plain language questions and read through all these websites and give you some more distilled information that's actually like readable so that you can continue that process yourself. And Dr. Taraga feels really strongly that we need to, as doctors, leverage these platforms ourselves. So I think the same goes for you guys, that there's tremendous potential. There's some shortfalls, but
Yeah, you're right.
That could,
Oh, go ahead.
I was going to say that could actually be an interesting proposition for us to study is how good AI is at finding a clinical trial. Because if we could identify a platform that actually provides, these are two clinical trials. When you type in your cancer, your grade, your histology, that would be incredibly useful to patients. And I don't think we know we really are at the beginning of starting to use AI and recommend AI in medicine. Uh, but as these companies grow and learn, that could be a useful place for them to provide information. Because I do think scrolling through the national database of clinical trials can take hours and
laborious.
be very confusing. Yeah.
Yeah, but again, that's something we do as patients. And so, if the, our medical teams, would have, the ability to narrow it down, then that would be an additional discussion.
Yeah.
And yes, I do know ACPMP does specifically look for the ones related to appendix cancer, PMP.
Yeah.
But again, we still need our medical teams to have discussions with us about those.
Yes.
Yeah.
Yeah. Yeah.
Let's see.
In terms of when we hope to have this available, I think we're looking at trying to get this out to many centers, sort of hopefully by the end of the year and having them start testing. We can't make it fully publicly available until that's started because we need to be able to prove that this tool specifically matters. But on the other in other good news, there's another center, UAB, and Kim Kopecki, who's a PSM surgeon there, is working really hard on this too. And she's a little bit ahead of us, I think, in terms of speed. So I think hers will hopefully be available even before. And we've been talking about coordinating how we can like pool forces moving forward too.
Yeah, well, and the other thing with your mention, I think the coordination that is done amongst our specialists that are familiar with this is incredible, and the sharing of information. So, we're happy to hear about that coordination. Let's see. There's a question on whether or not you have access to data scientists to help coordinate some of that.
Yes. Yeah, so most clinical trials, you work with a statistician very closely so that you make sure that you are powering the study appropriately, meaning that you have the right number of patients and everything. So we have one here at Yale who's working with us.
Great. Then another question that came in, this patient learned to talk to an oncologist about chemo treatment, et cetera, but spreading the message to make sure we talk to surgeons about surgical possibilities. Doctors who've never heard of this disease and its treatment can sometimes scare us patients because before you're in this world, you're not familiar with it, and you have this tremendous trust in really any medical professional, thinking that they'll steer you to the right place.
Yeah.
And go ahead, Nikki.
I was going to say it's really hard and it's really scary, and I think what we're trying to do is educate people so that even people who don't treat the disease, like Dr. Godfrey was saying earlier, are aware of the possibilities of how to treat the disease and that can the very least point you in the appropriate direction. And part of that is just becoming known and having people have heard of it. When the Whipple procedure was first introduced, people thought that it would never work. They thought that no one should undergo that procedure. They thought it was too dangerous. And now it's pretty standard for someone to say, well, I can't do a Whipple, but I'll recommend you to a center that can. And so I think the hope is that we'll get there with this disease process and this treatment as well.
Yeah, absolutely. Okay, so for the group, any other questions you'd like to put in the chat? Okay, but Dr. Godfrey and Nicole, this was so tremendously valuable, and it makes us feel, well, it does more than makes us feel. We are participating with you, and we really appreciate the update on this. And we're here with you as you continue on with the additional phases of this. But we can't thank you enough for spending your time with us this morning.
Well,
Thank
thank you
you.
guys for having us.
Yeah. And then for those of you that are new to our Hope Zoom calls, we'd encourage you to, keep coming back. We hold these Hope Zoom calls twice a week, Saturdays at 11 a.m. Eastern and Wednesdays at 6 p.m. Eastern. And, there's nothing like the peer-to-peer support that we're able to provide. So we hope you will join us, or, check out our website for our other programs. But thank you, everyone, for being here today.